Then fluid replacement therapy, double intravenous line should be maintained. Adults given 2 liter bolus fluid neglected, and children give 20 ml per kg bolus fluid. For disability dysfunction of the CNS, rapid neurological examination is done by ABPU method. A. Alertness, B. Voice response, P. Pen response, and U. Unresponsiveness. Raised intracranial pressure should be ruled out. Exposure and environmental support undress the patients completely, induce trauma. Seizures prevent hypothermia by warm blanket and warm fluids. Early hemorrhage control and warm room temperature maintained. So these are the methods. We are having the primary survey. In primary survey, first of all, we will do the airway and cervical spine immobilization. So first of all, the suctioning of the nasopharyngeal airway is done, then the chin lift and the jaw thrust is done. This is the airways. Then for the airways and cervical spine, the advanced methods are endotracheal intubation, cricothyroidotomy, and thyroidectomy and tracheostomy. Then for the prevention of cervical spine injury, we are having immobilized patient, avoid hyperextension of the neck, and apply cervical collars. These are for airway and cervical spine immobilization. Suctioning, chin lift, jaw thrust, cricothyroidotomy, endotracheal intubation, and tracheostomy. Then the prevention of cervical spine injury, immobilize the patient, avoid hyperextension of neck, and apply cervical collars. Now for breathing or ventilation, expose the chest and assess respiration rate and type. Okay, so for breathing and ventilation, expose the chest, give O2, then chest wall, lung, and diaphragm by inspection, palpation, percussion, and auscultation. Then do the pulse oximetry. Look for life-threatening condition that impairs ventilation. The distension pneumothorax, massive pneumothorax, and flail chest, and open pneumothorax, pulmonary contusion, and rib fracture. Any assisted ventilation needed or not. So for tension pneumothorax, wide bore cannula followed by chest intubation in 5th intercostal pace. For massive pneumothorax, requires vigorous circulation followed by chest intubation. For flail chest, managed by positive pressure ventilation. And for cardiac tamponade, needle pericardiocentesis issues which may be life-saving in short term. Thoracotomy and repair is required for definitive management. Okay, thoracotomy and repair is required for definitive management. Thoracotomy and repair. So for circulation, look for the signs of shock, that is skin color and hypotension, narrow pulse pressure, tachycardia, level of consciousness, and diminished urine output. So for circulation, look for the signs of shock, the skin color, the narrow pulse pressure, the level of consciousness, and the hypotension, the tachycardia, and diminished urine output. Then control the hemorrhage, apply direct pressure, pneumatic splint test devices, assess need for surgical intervention. Then for fluid replacement therapy, double intravenous line should be maintained. Adults given 2 liter bolus fluid neglected, and children given 20 ml per kg bolus fluid. For disability or dysfunction of the CNS, rapid neurological examination is done by AVPU method, that is alertness and voice response and pen response and unresponsiveness. Alertness, voice response, pen response, and unresponsiveness. Okay. So for disability, do the following method, that is AVPU, alertness, voice, and pen response, and unresponsiveness. And then for exposure and environmental support, undress the patients completely, prevent hypothermia by warm blanket and warm fluids, and early hemorrhagic control and warm room temperature maintained. So this was about the management of the patient, which is primary survey. In primary survey, airway and cervical spine immobilization, then breathing and respiratory support, then circulation and the prevention of hemorrhage, that is breathing, ventilation, and this is circulation, and the D is disability, that is dysfunction of the CNS, and E is exposure and environmental support. Now the secondary survey. So in the secondary survey, it is done after the primary survey and patient is resuscitated, that is vitals are stabilized. It includes the complete history, the complete head to toe examination, reassessment of the vital signs, complete neurological examination, and specific procedure and specific lab investigations. Okay, so first of all, the primary survey is done, in which A, B, C, D, E is maintained, A, B, C, D, E. Then secondary survey is done. In secondary survey, first of all, the history is taken, then head to toe examination is done, the assessment of the vital sign is done, and complete neurological examination is done, and lab investigations are done. These are the specific this is the specific method for the evaluation of the patient. First of all, the history is taken, then the detailed head to toe examination is done, then the assessment of the vitals is done, then the check for the neurological deficiencies is done, and then specific lab investigations are done. So the history is taken about the, this is the history, mnemonic, that is ample. So for A is allergies, for M is medication, for P is past illness, for L is last meal, and for E is events or environment or mechanism of injuries. So this is the flow for the history. Ample, allergy, then medications, then past history, then for L is the last meal, and for E is environmental or exposure or how the injury occur. Now for from head to toe examination, head is examined, in which the visual acuity is checked, conjunctival hemorrhage is checked, pancreatic injury is checked, contact lenses, dislocation of the lens, and ocular entrapment, bleeding from the head. Then maxillofacial structures are checked, which is palpate all bony structures, intraoral examination, assessment of the soft tissues, trauma not related to airway or bleeding can be delayed. For cervical spine and neck patient with head trauma or maxillofacial trauma should be presumed to have unstable cervical injury. Neck should be immobilized immediately until investigated. Cervical spine tenderness is checked, subcutaneous emphysema, tracheal deviation, and laryngeal fractures are penetrating. Injuries should be seen during examination of the neck. Okay. In chest, the thorough examination of chest wall to rule out open tension, pneumothorax, flail chest, or contusions. In abdomen, to note any intra-abdominal injury and drilled aggressively. Perineum, rectum, and vagina. So for perineum, for contusion, laceration, hematoma, and urethral bleeding, and rectum for bleed in bowel, lumen, pelvic fractures, or high-riding prostate, and vagina for any injury. Musculoskeletal system is checked. Extremities must be inspected for contusion and lacerations. Bones should be palpated. Movement of joint should be checked. Assessment of the peripheral pulse should be done, and for vascular injuries, the reassessment of the vital signs is done. It is done by clinical assessment, monitoring of the pulse rate, BP, and arterial blood cases, review of diagnostic results, use of the analgesia. In complete neurological examination, GSS, CNS, and deterioration, that is improvement in GCS. A specific procedure or lab investigation is done after the history examination. For suspected cervical spine injury, X-ray should be done as lateral view, additional X-ray, extremity spine, AP view, CT scan, contrast X-rays, urography, angiography, and endoscopy. In tertiary survey, okay. In tertiary survey, definitive care and support is provided. That is, patient is shifted to the ICU or OT or other respectively according to the need of the patient, and definitive treatment is planned. And tertiary survey is defined as patient's evaluation that identifies all injuries after initial resuscitation and operative interventions. Patient is more aware. More information about the mode of injury by patient is greater than trinodial death pattern, immediate death occurring with first few minutes of injury, then early death after few hours of injury, and late death due to sepsis, organ failure, etc. Okay. So this was the primary survey. This is the secondary survey. Done after the survey, patient is resuscitated. Vital stables includes, then complete history is taken and examination. First of all, head is examined, then maxillofacial structures and cervical spine and neck. It will go from head to toe. Head to toe. So first of all, the head, then the maxillofacial structures, then neck and the cervical spine, then the chest, then the abdomen, then the perineum, rectum, and vagina, then the musculoskeletal systems, and then the reassessment of the vital signs and the complete neurological examination, and then the specific procedure and lab investigations are done. Now in the tertiary survey, first of all, the definitive care support is provided according to the cause, and then the we are having the trinodal death pattern, so in which we are having the immediate death occurs in 50% of cases, and it is death occurring within the first few minutes of injury. Then we are having early death, which death after few hours of injury, and late death, which is due to the sepsis or organ failure, etc. Okay, so exam note. First of in the management history, examination, investigation and treatment questions, management questions, treatment. Okay. Now coming towards the next topic, that is aseptic technique and sterilization. Sterilization. So what are the different methods of preventing infection and the combination of cleaning, disinfection and sterilization? Asepsis and antisepsis. What is the decontamination, disinfection, sterilization, and the definition of these, and the methods of disinfection and sterilization, and the principles of use of prophylactic antibiotics, and what is asepsis and what is antisepsis? These are the important terms that we should know. So asepsis. Term asepsis refers to methods of preventing contamination of wound and other sites by ensuring that only sterile objects and fluids come into contact with them. Asepsis means prevention, sepsis means infection. So the prevention of infection is asepsis. Now antisepsis means anti means against. Okay, so antisepsis is use of the solutions such as chlorhexidine, iodine or alcohol for disinfection when infection has already occurred and now we are using some solutions, so it is antisepsis. Antisepsis is use of solutions such as chlorhexidine, iodine or alcohol for disinfection. Now there are methods of asepsis and antisepsis. Antisepsis methods: isolation, precaution, hand washing, use of gloves, mask, gown, glasses, use of disposable clean surface, staff health, hygiene and education, reusable medical devices and equipments. Cleaning is done with warm water and solvent detergent, and preventive vaccinations, inoculation and medicine, and the use of efficient devices for aseptic purposes. Now the antiseptic methods are chlorhexidine used for skin preparation and surgical scrub, then pyodine and iodine, and alcohol skin preparation, hypochlorite for skin preparation, and hexachlorophene for skin preparation. So these are the methods. First of all, we are having the methods of asepsis, and then we are having the methods of asepsis method and antisepsis. So it is to prevent the infection, which is isolation, hand washing, use of gloves, mask, glasses, disposable staff health and hygiene, reusable medical devices and equipments, prevention, vaccines, inoculation, and use of efficient devices for aseptic techniques. And antiseptic methods are chlorhexidine is used, pyodine and iodine is used, and cephramide is used, alcohol is used, hypochlorite is used, and hexachlorophene is used for antisepsis. Okay. Chlorhexidine, pyodine, cephramide, and alcohol and hexachlorophene. Now decontamination. So decontamination aims to eliminate or reduce levels of vegetative microorganisms and other unwanted materials from usable medical devices, equipment and surfaces. Decontamination aims to eliminate or reduce the levels of vegetative microorganisms and other unwanted materials from reusable medical devices, equipment and surfaces. Okay. Whenever there are microorganisms present, so the removal of it or the reduction of it and other unwanted materials from the reusable medical devices system is decontamination. So the medical methods are cleaning, that is aim of cleaning is to remove the contamination of, for example, blood, tissues, body fluids, degradation products, pyrogens, salts and dust from reusable devices and equipments. Then disinfection, it is defined as process intended to kill microorganisms with the exception of bacterial spores, and the classification is that we are having low, intermediate and high. So for low, reduce overall number of microorganisms but does not destroy tubercle, bacilli or bacterial spores. For intermediate, kills tubercle, viruses and fungi but only some spores. For high, kills most forms of microbes except for some spores. So this is the classification. We are having the decontamination, aim to eliminate or reduce levels of vegetative microorganisms and other unwanted materials from reusable medical devices, equipment and surfaces. The methods are cleaning and disinfection. In cleaning, aim is to remove contamination, for example, blood, tissues, body fluid, residues, degradation products, pyrogens, soils and dust. And the disinfection is that it is defined as a process intended to kill microorganisms with the exception of bacterial spores. Then we are having the classification, which is low, intermediate and high. So in low, reduce overall number of microorganisms but does not destroy tubercle bacilli or bacterial spores. In intermediate kills tuberculi, viruses and fungi but only some spores, and high kills most forms of microbes except for some spores. Now methods. The methods of disinfection are chemical agents, okay, and physical agents. So the chemical agents are alcohol, formaldehyde, 2% glutaraldehyde, and 0.1% sodium hypochlorite, while liquid gas and faster destroy hepatitis B, so I release chlorine to damage cell wall. Then for physical agents, we are having low temperature steam, which is exposed to 73 degrees C for 20 minutes at sub-atmospheric pressure, and boiling water, soft water, boil at 100 degrees C for 5 minutes. These are the methods. Okay, so what we have studied up till now, what is asepsis, then what is antisepsis, then what are the methods of asepsis and what are the methods of asepsis method. Then we have discussed the decontamination and we have discussed the disinfection. So in disinfection is classified into 3 phases, which is low disinfection, high disinfection, intermediate disinfection. Then we have discussed the methods for disinfection, which are both chemical agents and physical agents are used. The chemical agents are alcohol, formaldehyde, glutaraldehyde, and sodium hypochlorite, while the physical agents are low temperature steam, boiling water. Now sterilization. So by definition, sterilization is a process which destroys all forms of microbial life, including bacteria, viruses, spores, and fungi. Okay, sterilization is a definition process to destroy all forms of microbial life, including bacteria, viruses, and spores. Now the methods of sterilization. Sterilization by steam, that is autoclaving, sterilization by ethylene oxide, sterilization by hot air oven, sterilization by low temperature steam and formaldehyde, and sterilization by irradiation. Okay, and 2% glutaraldehyde, and sterilization by peracetic acid. These are the methods of sterilization. So the first method is the sterilization by steam or autoclaving at 134 degrees C. For 30 minutes, not for heat sensitive device at 121 degree for minute. Then sterilization by ethylene oxide, which is non-corrosive gas and can use for heat sensitive devices and highly cost. Sterilization by hot air oven used for fine needles, for example ophthalmic instrument, and temperature is 180. Sterilization by low temperature steam and formaldehyde at 73 degrees C used for materials which with integral plastic components. Sterilization by irradiation using gamma rays or accelerated electrons. Then 2% glutaraldehyde used as disinfection but also used for sterilization. Sterilization by the peracetic acid method involves liquid emergent denatured proteins destroy cell membranes by disrupting sulfur and sulfhydryl bonds, works at 50 to 56 degrees C for 12 minutes. Okay, now the objects and the methods. So for the dressing material and gloves, steams under pressure are used. For catheter, syringe, and IV cannula, gamma rays are used. For fine cutting edge, for example ophthalmic instruments, hot air is used. For heat sensitive material, ethylene oxide is used. For endoscopes, steresis, that is peracetic acid is used. Okay, for artery forceps and clamps, pressure and temperature is used. For switches materials, iodine is used. For thermometer and stethoscope, alcohol is used. For respiratory therapy equipment, formaldehyde is used. So these are the methods of sterilization. Sterilization by steam, sterilization by ethylene oxide, sterilization by hot air, sterilization by low temperature, sterilization by irradiation, 2% glutaraldehyde, sterilization by peracetic acid. These are the objects and these are the methods. Now the factors that contribute to asepsis in OT are patient preparation, then surgical preparation, instrument, and then surgical preparation. Factors contributing to the asepsis. Okay, so first of all you have to prepare the patient. So bacterial flora of patient is principal source of infection in surgical wounds. So showering with antiseptic solution and shifting, wear clean gown and shift to clean and shift to the clean bed, shaving, shave surgical site, and pending and draping antiseptic 10% iodine applied. Then the surgical preparation, that is surgical instruments are cleaned, disinfected, and sterilized. And the surgeon preparation, hand washing, gloves, mask, and hair cover, and surgical gown. These are the surgical preparation. Then the preparation of the OT, which is dirty area should be prevented, temperature regulated between 19 degrees C to 22 degrees C, humidity that is 45% to 55%, adjustable lights, and air should be filtered. Then the surgical techniques are avoid poor tissue handling, and the prophylactic antibiotics are pre-op antibiotic at the time of anesthesia. Pre-op case, antibiotics are given, good surgical procedures are done, asepsis is done, and good nutrition is provided. And in post-op care, antibiotic prophylaxis and remove drain as early, and dressing is done, and start enteral nutrition and glycemic control, and short stay in hospital is done. Now, the principal use of prophylactic antibiotics. Prophylactic antibiotics should be administered for operative procedures that have high rate of post-operative surgical site infections or when foreign materials are implanted. It should be effective against aerobic and anaerobic pathogens most likely to contaminate surgical site, that is gram-positive skin and or normal flora coloning incised mucosa. Should be administered within 120 minutes prior to incision or should be given at the time of anesthesia. So these are the methods of disinfection and sterilization. We have discussed the term asepsis, which is preventing contamination of wound. Then antisepsis, which is a use of solutions such as chlorhexidine and iodine or alcohol for disinfection. Then we have the asepsis method and antiseptic methods. In aseptic methods, prevention is done, and in antiseptic methods, solutions are used. Chlorhexidine, pyridine, and cephamide, alcohol, and hypochlorite. Then we are having the decontamination. And decontamination aims to eliminate or reduce levels of vegetative microorganisms and unwanted materials from reusable medical devices, equipment, and surfaces. Then we have methods of decontamination: eliminate or reduce levels of vegetative microorganisms. Okay, what was antisepsis? It was a use of solutions to prevent disinfection. Now, what is disinfection? Decontamination. It is the aim to eliminate or reduce the levels of vegetative microorganisms, and the cleaning is aim of cleaning is to remove contamination. Then we have disinfection, and it is a process which is intended to kill microorganisms with exception of bacterial spores. Only microorganisms are killed. So the classification is that we have low, intermediate, and high. In the methods are chemical agent and physical. In physical, temperature is used and boiling water is used. In chemical agent, alcohol, formaldehyde, glutaraldehyde, and sodium hypochlorite is used. Then we have sterilization. It is the definitive process destroys all forms of microbial life. In disinfection, we describe the bacterial and define the process which disinfection kill all microorganisms except bacterial spores. While in the sterilization, all kind of microorganisms are killed. So we have the sterilization by steam, sterilization by ethylene oxide, sterilization by hot air oil, sterilization by low temperature, and sterilization by irradiation. And 2% glutaraldehyde is used for sterilization, and sterilization by periacetic acid is done. Then okay, then we are having the objects and methods. So these are the objects and these are the specific method. For dressing material and gloss, steam is used for catheters and syringes. Gamma rays are used for cutting aids and ophthalmic instrument. Hot air is used for heat sensitive material. Ethylene oxide is used for endoscopes. Stereosis, paracetic acid is used for surgical instruments. Steam is used for artery forceps. Pressure and temperature is used for suture materials. Iodine is used for thermometers, stethoscopes. Alcohol is used for respiratory therapy equipment. Formaldehyde is used. Now the factors that contribute to the asepsis in OT are patient preparation and surgical preparation, instruments and surgeon preparation. The bacterial flora of the patient is principal source of infection in surgical wounds, and showering, shifting, shaving, and pending and drying. And this is a preparation of auditory area should be clear, temperature is regulated, humidity adjustable, lights and air should be filtered. Surgical techniques are avoid poor tissue handling, and prophylactic antibiotics are pre-op antibiotics at the time of anesthesia. Now pre-op care, so we are having antibiotics, good surgical procedure, asepsis and good nutrition. In post-op we are having antibiotic prophylaxis, remove dryness, early dressing, start enteral nutrition, glycemic control, and short stay in hospital. Now the principle use of prophylactic antibiotics. So prophylactic methods should be administered for operative procedures that have high rate of post-operative surgical site infection or when foreign materials are implanted. It should be effective against aerobic and anaerobic pathogens most likely to contaminate surgical site, that is gram-positive skin or normal flora coloning incised mucosa. Then should be administered within 120 minutes prior to incision or should be given at the time of anesthesia. Now coming towards the next topic, that is nutrition. So we are having the severe malnutrition, injury and mode of nutrition, different methods of nutrition support, what are the complications, and what is the mode of nutrition in traumatized patients. So the effects of malnutrition on surgical patient: there will be delayed wound healing, there will be reduced ventilatory capacity, there will be reduced immunity, increased risk of infection, there will be prolonged hospital stay, there will be disrupted mucosal barrier, and there will be increased mortality. Okay, delayed wound healing, reduced ventilatory capacity, reduced immunity, and increased risk of infection, prolonged hospital stay, disrupted mucosal barrier, and increased mortality. Now, how you will do the nutritional assessment? So first of all, you will do the clinical history, then the physical examination, that is muscle testing, then the body mass index, that is a BMI check, anthropometric assessment is done, and laboratory test used for nutritional assessment. Okay, clinical history, examination, body mass index, anthropometric assessment, and laboratory test. Anthropometric assessment means BP, pulse, respiratory rate, and Glasgow muscle, all these are done. Okay, so the calculation of energy requirement is done by basal energy expenditure multiplied by injury factor multiplied by activity factor. Okay, calculation of energy requirement is done as such: basal energy expenditure multiply by injury factor, multiply by activity factor. Now, what is enteral feeding? It refers to any method of feeding that uses GIT to deliver part or all of person's caloric requirement. Enteral means intestinal, so GIT is known all. It refers to any method of feeding that uses GIT to deliver part of or all of person's caloric requirement. Then the assessment should be done before embarking on external feeding. Small intestine should be functioning. Okay. So, it refers to any method of feeding that uses GI to deliver part or all of the person's caloric requirement, and assessment should be done before embarking on internal feeding. Small intestine should be functioning. If the small intestine is functioning, then this method is used, that is enteral feeding. Then the indications for enteral feeding as well: protein, energy, malnutrition with inadequate oral intake, dysphagia of for solids, unconsciousness, debility, anorexia postoperatively, enterocutaneous fistula, that is distal low output, and for enhancing adaptation after massive enterotomy. These are the indications for the enteral feeding. What are the indications? Protein, energy, malnutrition with inadequate oral intake. Then dysphagia for solids. If solids, it is difficult to consume the solids, dysphagia. Then unconsciousness, then debility and anorexia postoperatively. Then enterocutaneous fistula is present, that is fistula is present in the intestinal region, and there is low output, and for enhancing adaptation after massive enterectomy. The contraindications of enteral feeding is that small bowel obstruction, paralytic ileus, and severe diarrhea, and proximal small intestinal fistulas, and severe pancreatitis. These are the contraindications of the enteral feeding. Okay, so this is the GIT system, gastrointestinal tract, and here the tubes are used, that is gastronomy tube, and here is the jejunostomy tube. So whenever the nutrition is provided in the GI tract through a tube, then it is termed as enteral feeding. So we have discussed the indications and contraindications for enteral feeding. Okay, that's it. So we have discussed these are the indications: malnutrition, dysphagia, unconsciousness, anorexia, enterocutaneous fistula, and enhancing adaptation. And these are the contraindications, that is small bowel obstruction, paralytic ileus, severe diarrhea, proximal small intestinal fistula, and severe pancreatitis. Now, what are the routes of administration? So the routes of administration are oral, tube gastrotomy, and tube enterocostomy. Okay, tubes are inserted orally. It can be given orally. Tubes can be used nasogastric tube through nose. Tube gastrostomy, that is in the stomach, tube can be used, and enterostomy, that is a tube in the intestine, can be used. Now the method is that oral supplements or sip feedings are given. Nasogastric or nasoenteric food used for duration of 6 weeks, and tube gastrostomy or enterostomy can be used. The nutrient formulation: polymeric liquid diets are given, blenderized and elemental diets are given. Rate of the infusion and strength of the initial food. The advantages of enteral feeding and the complications. The advantages are that it prevents intestinal mucosal atrophy, maintain gut barrier function, and decrease post of infectious complications. It supports gut associated immunological shield, and it attenuates hypermetabolic response to injury and surgery. It is cheaper than total parental nutrition and has few complications, and no IV access is needed. Complications are feeding tube, that is malabsorption, malposition, dislodgement or migration and aspiration, perforation of the intestine, peritonitis, abscess formation, fistulas formation, intestinal obstruction, and tube fracture or blockage. The feeding regimen should be feed intolerance, diarrhea, vomiting, and hyperglycemia. Reduction of the rate of infusion along with insulin therapy provides effective treatment, and entering infection to prevent this complication. Discard contain after 12 hours. Now, parenteral nutrition. So defined as provision of all nutritional requirements without the use of gastrointestinal tract, and it is employed when there is intestinal failure, that is a reduction in functioning gut mass below minimal necessary for adequate digestion and absorption of nutrients. Whenever there is defect in the gut, then the parenteral nutrition is given. And the indications are: absolute indications are proximal enterocutaneous fistula when there is fistula, and relative indications are mood or severe malnutrition, severe inflammatory bowel disease, severe pancreatitis, prolonged ileus, abdominal sepsis, major trauma and burns, and massive intestinal obstructions. Now, the contraindications of the parenteral nutrition. So these are congestive cardiac failure, blood dyskaryosis, uncontrolled diabetes, fat metabolism disturbance, and liver failure. The routes of administrations are catheters, that is peripheral or central veins, peripherally inserted, that is central catheters, and CVC implanted pod. Okay, so parental nutritions are done by using the GI tract and tube is inserted. It was enteral nutrition. Now parental nutrition is used through IV cannulas or and the GI duct is not used, and the contraindications of this are congestive cardiac failure, blood dyskaryosis, uncontrolled diabetes, fat embolism, and liver failure. Okay, if these are present, then this nutrition should not be provided. The complications are related to feeding catheters, that is the problems of insertion. Catheters are used for the parenteral nutrition, so there will be the problems of insertion, that is failure to cannulate, pneumothorax, anterior puncture, brachial plexus injury, mediastinal hematoma, and thoracic duct entry. Then there will be the problems of care, which are catheter-related infection, infective endocarditis, and embolus, central venous or cardiac thrombosis, thrombotic catheter occlusion, and catheter migration or embolus. Okay. So now these are the complications that is related to the feeding catheter, and related to the feeding regimens are hyperglycemia, hypoglycemia, hypertriglyceridemia, electrolyte disturbances, that is hyponatremia, hypokalemia, and acidosis. Then trace elements, that is vitamin C deficiency and deranged lefties essential fatty acids deficiency. So this was about the enteral condition related to feeding catheters, problems of failure to cannulate, pneumothorax, arterial puncture, brachial plexus injury, mediastinal hematoma, and thoracic injury. What are the problems? These are catheter-related infections, infective endocarditis, embolus, central nervous system, and thrombotic catheters. And the relating to the feeding regimens are hyperglycemia, hypoglycemia, hyperglyceridemia, and electrolyte disturbances. Okay, so in the start of the unit, we have studied that the question that are what is a severe maxillofacial injury and what will be the mode of nutrition. Okay, then different methods of nutritional support. So it was enteral and parenteral. Then the complications of nutrition support. Okay, so in comatized patient, we will use the this method, parenteral nutrition. Comatized patients, parenteral nutrition. And in the patients of severe maxillofacial, we will use the enteral nutrition. Okay, these are our answers. Nutrition. So this was about nutrition.